turn things over to you, Andy, to kick this off. And thank you all for being here and enjoy the conference in the first session.
Hey, awesome. Thank you so much. This is a fun session to do. And I think I've had the opportunity to do it every year that we've done a panel session with the state EMS directors. And right off the bat, Matt, I'm going to throw you a curveball because I think that Katie Holstein, who is the state EMS director in Washington, is also somewhere sitting in the crowd. If she's willing, Katie, if you're hearing this and you're willing, we could pull you in. We'd love to pull you in on this panel. She hasn't been prepared with the questions, and so we can just fry her. But we'll let all the experienced ones talk first. If Katie, if you're willing to do that, Matt can pull you in as a panelist. I'm quite certain. But at any rate, welcome and thanks for joining the Rural EMS and Care Conference. This is the session that we're about to do is a session that's supposed to be interactive, in which I get to talk with my colleagues, and I'll let each of them introduce themselves here in just a minute. My name is Andy. I'm the former state EMS director from the state of Wyoming, which is how I came to know all of these guys, and also how I met Matt and connected with NoSOR. I now work for the National Association of State EMS Officials as the Deputy Executive Director. So it's good for me to be back in and working with my colleagues here. So with that being said, the main thing here is that we want to answer those questions that you all have. I can sit and talk to my dear friends, Terry and Marty and Guy all day, but we want to get to the questions that you've got. I have some questions that they've already seen, and that we're prepared to just keep on talking until you all say something. But please, if you have a question that you want to hear from one of their states, then put that in the chat, and Matt will help keep me on pace, making sure that I'm seeing the questions and that we're interactive. So with that being said, gentlemen and lady, who is now going to be joining us as a panel, I'm going to let you introduce yourself, and I'm going to introduce by my screen here on the Hollywood Squares. So we'll start with Terry, who I think is probably the most tenured of the state EMS directors. But Terry, you want to say hi and introduce yourself?
Thanks, Andy. What I'm struck by most is the fact that we've actually got the prettiest of the state EMS directors presenting today. What a handsome bunch we are. Anyway, yes. Terry Mullins, State of Montana, EMS and Trauma System Section Supervisor.
Yeah, thanks, Terry. And I'm just going to assume that you meant Katie when you said that, because the rest of us are busy. We need the furniture wax out here to polish all of this. Guy, next up to you.
All right. It took me a few minutes to get logged in, but I'm here. My name's Guy Danzy. I'm the state EMS director for Utah, and been involved with state projects and at the state level for almost 20 years, and EMS being about the last 15 of that. So excited to be here and happy to entertain any conversations or questions or anything else. And Terry, you are one of the good looking ones. What are you kidding me?
That's just going to go to his head, Guy. Let's not do any more of that. Marty.
Hey, thanks, Andy. Good afternoon, everybody. Marty Link, State of South Dakota. I've been the EMS and Trauma Director here for, about 7 years, with the state for about 20 years total. So a little bit seasoned, as you can tell, if we're continuing on with the jokes there. But I like this opportunity. It gives opportunity for folks around the country, those working on services, to ask us specific questions. We're for the most part an open book, and I love the dialogue, and I think Guy and Terry do as well. And Andy, just being able to answer questions and give some insight from our perspective, and then in turn we hope to get that perspective from you. So thanks for the invite, Andy.
Yeah, absolutely. And Katie, late addition to the panel. Would you like to introduce yourself?
Hi, Andy. This is Katie. I'm just trying to start my video here. Thank you for the opportunity to join your panel. I appreciate that. I'm Katie Holstein. I'm the State EMS Director for Washington State Department of Health. Also very pleased to have this bi-directional conversation between the state EMS offices and the various partners that are joining us today. I think it's critical to continue the dialogue, particularly in the need to continue to evolve our EMS and trauma care systems to meet the needs of the changing environments. So very, very happy to be here, and thanks again for the invite.
Yeah, thanks for joining, Katie. Well, I think one of the skills that a state EMS director learns over the years is the ability to just jump up and start answering questions at any given point to any audience. So Katie's demonstrating a skill that we've all developed over the years. So there we go. That's your panel. We've got 4 different states represented, and the whole idea here is to bring out new ideas and innovations and what's going on in these different states, so that all of you then who are observing and listening to the panel discussion can then carry that back to whatever state that you're in. Sometimes it's a great fit, sometimes it's not. Sometimes you just sit there and go, man, I'm glad that that's not going on in my state. That's often the way that we feel when we're talking to each other. But with that being said, we'll just kick this off. And so just again, to reaffirm, please put your questions into the chat, and we will get them, and we will try to make sure that are answered. And Matt, if you can just kind of keep an eye on that for us to make sure we get to them. But anyway, gentlemen,
Andy, real quick,
we'll get right. Go ahead. Yeah.
can I amend your statement to
Go
say
ahead.
put the questions into the Q&A so I don't get them lost in the chat? I'll monitor the chat to make sure I don't miss any, but if they can use the Q&A feature, that'd be great.
Oh yeah, sure. And my bad. I just realized that that was a thing. So I now have that open so that I can see it. So that's good. Thank you. Good clarification. Put them into the Q&A, and if you're looking down at the bottom of your screen, you should see that icon there. But any rate, gentlemen, we'll get right to it, and we'll start with just the first question right off the bat while we're waiting for some questions to come in. With the congressional passage of the American Rescue Plan Act, many of the states, your states are, and I said, gentlemen, I'm so sorry, Katie, I'm going to have to shift my brain. Your states are getting assistance with money that is earmarked for healthcare and EMS. And so the question to you is, to the extent that you're able to discuss it at this point, how much do you anticipate getting? And more importantly, how do you intend to leverage that? And Marty, let's start with you.
Sure, thanks, Andy. So I'm seeing some questions come in, and there's some really good questions here in the queue. But to your point, we've been very fortunate in the state of South Dakota. Both Governor Kristi Noem and the South Dakota legislature approved about $22 million of ARPA funding for the state. So one of them was a constituent request to the governor's office. One thing that we'll be doing is about a $12 million project to replace aging LifePak defibrillators. Okay, so we know that's great. The equipment is essential. We're looking at this from a system of care perspective, but we need to have those people in the seats and the people operate that as well. So another project that we're doing, which is about an $8 million project, is what we're calling a regional service designation. So this is going to allow us to do a statewide comprehensive analysis of really the state of EMS. And we've done similar things before, doing surveys of EMS directors, surveys of city and county officials, but this is going to take it to a much broader level. And then the last thing that we're doing, I'll keep my comments short here so the others can join in too, but the last thing we're doing is a telehealth initiative where we're going to be implementing telehealth services to all ambulance services. We're really excited about the possibility that brings, especially in rural and frontier America, which South Dakota is split right in the middle there. So I'll turn it over to the rest of the guys.
All right, let's go to Montana. That would be you, Terry. If we can pivot to Guy if you need us to, or you got your audio there.
I need to change my glasses so I can find my mouse. Sorry.
All right.
So while that statewide telehealth initiative sounds like a great idea, we also got some pretty significant funding through the CDC health disparities and COVID-19 grant that came out, and we're administering several million of that through a couple of our partner organizations here in the state to fund both community health worker positions and community integrated health positions, hopefully so that we'll have some penetration in all 56 counties around the state. That kind of adds to 10 or 12 agencies that are currently providing community integrated health activities. We also have about $1 million that we're using from that grant to fund the purchase of laptops for the use by EMS agencies, and also trying to pay for their internet connectivity, their cellular connectivity for those units. And then we have $1 million for kind of a seed project to establish telehealth programs as well. This will be hopefully partnerships that will incorporate either an EMS provider or a community paramedicine provider, along with a hospital or healthcare organization. And we're just kind of getting started on that, so we don't have any results yet. But all in all, we're, when you look at over time, we've had a pretty significant influx of money that we've been able to push out to EMS providers compared to previous years. So that's a positive thing.
Okay, thanks. Utah.
All right. So we received about $6 million of the ARPA funding. We took some of that, $100,000 off the top, to help us with some of our data management system. ImageTrend is what Utah uses, and trying to bridge that over for our background check information. So a little bit of that funding went there, and then about 300,000 went to one of our two-year institutions to help promote rural EMS training. So that was specific to a small school in South Central Utah, and they're doing outreach courses, and they're trying to use virtual training and those kinds of things to help the rural situation with staffing, as all of us face that. And then the rest of it, about 5 million of it, went to EMS grants, one-time rural EMS grants, and we qualified all of our rural EMS ambulance providers. So we do have some quick response type providers, but this just targeted the ambulance services, and we basically opened it up to them to decide whatever they needed most, with the emphasis being on staffing, staff retention, recruitment, training, and then the other idea is for ambulances or equipment. So, and we had that administered. I worked closely with our legislators and our association of county governments that we have in Utah. So they're actually administering the funds, but we work closely with them to set up the criteria and let them use that money to help themselves. So we're very happy about that. Did you want me to address telemedicine a little bit? Utah's been working on a couple telemedicine issues, but maybe I can get into that a little bit as we talk about different things the states are doing. Is that okay?
Yeah, that's fine. Let's maybe go to, but hold that thought, because I actually jotted that one down. And so just keep that in your mind, guys, as we come around to that. But Katie, what's up in Washington as it relates to ARPA funding and your status out there?
Well, in Washington, we have funding from a variety of sources right now. We have a little bit of funding for EMS, and what we've done with some of that funding, we do provide some vouchers to rural communities for the national registry testing. Some of the funding goes through that. We do pass through funding to regional councils. In our state, our regional councils are quasi-governmental organizations, and they can give funding to EMS services for training. So there was some pass-through funding for training. We've done a few different education efforts and videos to help rural communities with different types of education. In terms of the funding that's becoming available, there's a whole lot of funding that we're hearing about and learning about. And we'd love to continue giving funding to rural EMS services for improving sustainability. And you'll learn more about that project that we're conducting here in Washington from John Noakes later in the conference. He's going to provide information about that program, and what we'd like to do when that funding is over is continue that program because it's been so successful. So we're excited to see a lot of the funding become available. We do have some ideas on how it be used. Much of our efforts are targeted towards rural communities, improving their sustainability, improving recruitment and retention. Anything that we can do to package and deploy education, funding, and self-deployable activities to improve the attributes of a successful EMS system. So that's a little bit of what we're doing here in Washington.
Yeah, thanks, Katie. And we can just pivot right from there to the first question in the Q&A box there that I'm sure you all have seen already from Bill Spencer, who's in rural Idaho. And of course, he's asking about workforce. That's a huge issue all across the nation in both rural America and in urban areas. And so Bill's question is, what ideas are you coming up with, or is there anything unique that's going on in your state that you're aware of to help address the recruitment and retention? And now, Guy, I'll come back to you on this one right off the bat, since I can see you nodding your head there, but you want to take that one on first?
Yeah. And I got excited because I saw that health insurance. So this year, I've been working with the legislator, and I've got to be really good friends with him, an older gentleman in northern Utah, and he's very concerned about rural EMS. And one of the things that he worked with another legislator that the previous year had pushed on an insurance for EMS volunteers idea, but it came in late in the session. It didn't get a lot of traction. So he picked that up this year, and he just passed the bill. We just signed it into effect. I actually was able to go to the bill signing on last Monday, a week ago. And what we're trying to do is offer insurance for EMS volunteers. And in Utah, most of our urban areas are all concentrated around Salt Lake, within a few miles, maybe 100 miles north and south of Salt Lake. So it's pretty easy to delineate who is rural and who's not rural in Utah. But we're looking at all the counties surrounding that donut in Utah, the outside part of it. And we're offering the counties an opt-in insurance program. The state is subsidizing the vast majority of the cost, but I'm setting up an advisory committee and working to develop the criteria for who's eligible. But super excited about it. Hopefully that will help out. And that's just one of the things we're working on right now, just for that staffing issue. I don't know if it's the silver bullet, but we feel like it might be enough of a carrot that it might keep people in there, or it might allow some people that retire early to continue to work in EMS and get that insurance. Anyway, that's enough for me, but thanks.
Sure. Thanks. Terry, what about Montana?
Thanks, Andy. I don't have a whole lot more to add. We did pretty extensive survey of hospital and EMS managers a couple of years ago to identify threats to EMS and possible solutions. And Montana, like all Western states, it has a pretty extensive number of agencies. The majority of our agencies are volunteer or partially volunteer, and they're dramatically struggling with recruitment and retention, just like other states. So among the recommendations that came forward from that survey was the creation of a statewide EMS association. There's not currently one in Montana. In hopes that that organization would be able to be responsive to requests from legislators like Guy's just describing from Utah, who have a desire to help improve and enhance EMS in rural areas, but they haven't had someone in the state of Montana to really go to kind of get ideas and to bounce ideas off and to gain support. So that's one of the things that we're doing here that we hope will help. One other idea that I heard was brought up last year but I don't know if it will come forward again this year, was to also make it possible for the families of volunteers to have some paid tuition or some tuition reimbursement for their family members to go on through the community college system. So you're kind of supporting the parents while they continue to do volunteer work by supporting their children as they go through higher education.
Oh, interesting. Good. Thanks, Terry. Marty?
I think this is $1 million question. You know, when you talk about it from the state level perspective, there was a bill that came forth this year to talking about a retirement, bringing in some folks from EMS into the retirement system, and they're going to have to revisit that next year. But I would also, encourage folks, not only look at this from a state level, but look at it from a local level too. What are incentives from local businesses, local municipalities to be able to help with some of these recruitment issues? And I think one thing that I've noticed just traveling across the state is, when you look at some of these EMS 8 organizations, you can see there are many that take just tremendous pride in their building, their structure, the way they operate that ambulance. And then there's others that vary a little bit. And sometimes that variance is, they're pulled in so many different directions, much like all of us in our lives. There's times where we're pulled so much that we can only give to a certain degree. But what I would encourage a lot of folks in the EMS industry is look for some of those key stakeholders in your community that would never darken the door of an ambulance, because that's just not that gifting that they have, or they get, sick by the sight of blood and all that good stuff. But they might be a heck of a banker. They might be a heck of a marketer. They might do a great job with policies and procedures, something to incentivize others to be able to come on board. And the question is so profound, because we talk about how do we bring more volunteers into the organization, and that's key. I mean, you've got to make that ambulance be one of the most respectful businesses in that community, where you almost draw people into it because there's such a following there. And it takes incredible leadership too. I mean, these are positions where you're taking volunteers, you're taking paid providers. They're seeing all kinds of things that you see in the field, taking care of patients. And I mean, just the everything that goes into it from that business perspective is really key to having that solid leadership. But I would encourage people, just look within your community too, because there's a wealth of resources almost right in front of you that can help with some of these initiatives.
Yeah, thanks, Marty. I think that's a key point. And one of the things that I have pointed out to folks or talked to folks about is, often not just in rural EMS, but, when we say, hey, what's your number one issue? Workforce. We got a problem with workforce. Then you look around the organization and they'll have a training officer or field training officers, and we got somebody that's in charge of maintenance, and we got somebody who's in charge of the annual, awards banquet, recognition banquet. But who did you tap on the shoulder and say, hey, I need you to be in charge of recruiting and retention? Like, I need you to prioritize that as your effort here. So I think you raise a very valid point there, Marty. Katie, what's your take on the question? Anything innovative going on with workforce in Washington?
I think we get a lot of questions. Yes, we certainly do. And you'll hear more about the sustainability project John's doing later this week. But in terms of what we can do at all levels of our system, when I'm asked questions from legislators or grants or assessments or anything, I think there's 4 common themes that I advocate for and repeat in terms of building rural communities. One is I think it's critical, especially in our state, to do an EMS workforce study, because we want to be able to take the funding and provide funding and initiatives targeted towards solutions that are more specific. So I definitely think that if you've done that, or either at a local level or at a state level, that's going to help inform what the funding is going to be used for and how you're going to use it. I think funding to support EMS leadership in communities leadership training is critical. what we have learned in working with rural communities is they really need leadership training. They need to be plugged into a wider system. It's really helpful for them to learn leadership principles and practice communicating with each other and sharing experiences, building capabilities, knowledge, skills, and abilities for leadership. The third is anytime that we can advocate for incentives, some have already been mentioned, but tax incentives like vehicle tax, exemptions, college tuition credits, the option to enroll in your state health, benefits or retirement benefits, pension programs, disability insurance or deferred benefit plans, payment for expenses such as equipment, transportation or uniforms or meals while on duty, free passes to municipal services such as pool or parking. We saw a piece of legislation proposed a couple of years ago where people who volunteer for EMS and fire services could potentially get a hunting fishing license for free. Unfortunately, that didn't pass because it would be such a drop in revenue, but it was very popular and an interesting, innovative approach. So we liked seeing that. And then I think there's systemic solutions that you have to consider as well. Is there levy constraints to local EMS levies or establishing there? Promoting regional, approaches to providing training and sharing of resources, and certainly the adoption and the implementation of community paramedic programs in rural communities where your volunteers are stretched really thin as it is. And some of these community health worker and community paramedic programs can lower the call volumes for the types of patients that might use EMS for the primary health care. So I think in terms of what we're advocating for, that's some of the work we're always looking to do and always advocating for in Washington.
Yeah, and did we look? Sorry, I think I started talking right when you were finishing up there, Katie. My apologies. I don't know if I walked
I'm all
on
done.
Okay, I don't know if I walked in you or not, but I was going to tell you, don't turn your camera off, Katie, because we're going to go right to you on the next question, which is in the Q&A box, since you've had a chance to read it and prepare just as much as your fellow panelists here. And again, just encouraging everybody that's in the attendance here, if you've got questions that you'd like to hear these folks answer, please put them in the Q&A, not in the chat, so we keep track of them. But so going right to you, Katie. Lots of states to manage the pandemic. We changed our minimum staffing levels and created lots of things in order to kind of expand the workforce. And the question from Scott there is, are you concerned about the quality of the folks that are out there providing care right now? And what do you plan on doing about it? Did your state do anything like this? Are you looking at reverting, or have you had any issues, or what's your take on that question there, Katie?
Well, Washington does have a law that passed that allows non-medically trained drivers in rural communities. And so we've had that since 2017. Many of our rural communities have adopted the use of non-medically trained drivers. And we haven't yet heard of any issues related to the decrease in quality. Are we concerned? Organically, I think, yes, we all probably share some concerns that the quality of care could decrease if we lessen the standards of staffing and equipment requirements. However, I think we need to be able to substantiate those concerns with existing data and be able to measure data for improvements. And in our state, we're still in the incipient phases of being really good at collecting our data and doing some data quality efforts to improve quality of data so it's usable for us. And it's difficult too in rural communities. We do have a state mandate for data collection now, but in rural communities, there's a more difficulty with infrastructure in establishing electronic patient care reporting systems and reporting data. And until we start doing that, I don't know that we can substantiate the concerns using data, which I think is an important consideration in balancing the leveraging of the providers that you have and the barriers and burdens that regulations and staffing and equipment are now, coming to a point, especially coming out of COVID, where we're very vulnerable. And in our state having a vaccine mandate, we saw a significant decrease in volunteers. So there's a balance there, and I think it should be evidence driven. So it would be remiss of me to say I'm not concerned as a healthcare provider, as a paramedic. Sure, I share concerns, and I think equity and equality in care is certainly a lens that we want to look at this situation. But it should be a data-driven, data-driven conversation, and not just based on arbitrary feelings of concern. And I think that's important in moving forward and considering what we need to do to help rural communities. That may be an unpopular opinion, but that's mine. That's my opinion. I stand by it.
Got it. Terry, how about you? What about Montana? Did you guys have to alter anything at all, and are you worried about it?
During COVID, we introduced a standing ability for an agency to use a trained driver as one of the 2 attendants. And that has been part of the regulatory package available to certain rural agencies for quite a long time. The question about whether or not I'm concerned about it, I think I would answer it this way. I'm more concerned about having an ambulance show up, period, in some of our communities that are most distressed than about whether or not one of the individuals is a trained driver. Not because I think it's for this reason. I think COVID has forced us to recognize, in my opinion, that our vision of what EMS is and should be needs to dramatically change, because I think that there are circumstances that we just are not going to control about rural populations, rural tax bases, and rural demographies that may very well mean the provision of EMS, the definition of EMS has a pretty dramatic change. And so I think the use of a trained driver is one of the creative ways that we can, it's recruitment and retention. It's one of the activities that we have to consider for keeping rural EMS in place. So I'm concerned just because it's one of the new lenses that we have to look through EMS, and so that we need to then come up, like Katie said, we need to come up with a way to evaluate its impact from a data perspective. But I think it's a legitimate pathway forward that we just need to kind of keep studying. And there are others, and there's going to be other changes too.
Got it. Marty, how about South Dakota?
Yeah, so I love these questions. So we instituted, we adjusted our minimum standards. So it used to be 2 EMTs on every crew. And then this was 5-7 years ago. We went to a driver and then an EMT at that base level. And, it's interesting when you look at these questions, but how we look at it from our state is, we've got to expand our workforce. We've got to have an influx of people coming in, like Terry alluded to, because we want those trucks to be able to respond. We want them to get to those patients. But we also hold accountable those local ambulance services and EMS providers. Everybody that got into this business took an oath. One of the first pages of the textbook, if you remember that. And we have an obligation to our patients. We have an obligation to our ambulance services, and medical directors out there should have an obligation and do have an obligation to supporting your crew. And the reason I bring that up is there's checks and balances to everything. So you have EMS crews go on a call, they sit down, they review that. What went well? What do we need to adjust differently? You have medical direction oversight that does the same thing. So, are there concerns out there about quality? Yeah, I mean, it's healthcare in general. We've got to look at, there's always performance improvement processes that need to be in place. More concerning to me is, are those checks and balances in place? Are they active? Are people looking at that on a constant basis? Not from a punitive nature at all, but more of, how are we doing? How can we improve this? Our whole model for the longest time is, driving the system of care perspective, and that's bringing everybody together to improve healthcare in general. And EMS is certainly an instrumental component to that. So there's always going to be those concerns, but as long as you have those checks and balances in place, hopefully any issues or potential issues are caught, addressed, and people are able to correct them and move forward. So
Great. Guy?
Yeah, I think Terry and Marty kind of hit some of the topics that we're dealing with here. COVID, we did allow some waivers of our rules. We have similar to Marty, we have a 2 EMT or more requirement on every scene. But the reality is sometimes there's only a driver and an EMT. And so, we had to look at that and take a good hard look during COVID. We currently have a problem in some of the most rural areas, frontier areas, in getting EMTs to commit, or people committing to become EMTs. So we're looking at doing a EMD as a stepping stone and maybe having a waiver, maybe time limited for a year or whatever. We just took that to our EMS committee a couple weeks ago to talk about. But we're working on trying to at least hook some of these young people into the system by letting them be an EMD as a stepping stone to EMT, and hoping that works out. One of the other things, Marty touched on it, a year ago, we had a bill that passed for EMS as an essential service. And this requires that all political subdivisions of the state, that means counties, cities, or special service districts, have skin in the game with EMS. They have to provide it or have it provided for their people. And so that's helped a little bit. I think it's made it a little more serious for county commissioners and mayors and councils to take a deep look at what they're doing and how they're funding it on a local level. The other problem we have is we have a large tourist population. A lot of our people that are responding it's not responding necessarily to their neighbors down the street. It's responding to people from out of the country or from Salt Lake area out into the parks and things like that. So we've had those conversations at the legislative level and tried to reallocate funds and make rural EMS a higher priority because it affects all of us. I'm probably like Terry. I see him nodding his head. I recreate in the areas where we consider it frontier, and I don't want to be out there and not have somebody not show up. That's the message that we've had over and over with our legislature the last 3 years, is that we've got a serious problem here and we're all affected by it, even if we don't live in those areas. Anyway, that's my 2 bits. Thanks.
Yeah, no, great. There's so many layers to this whole workforce and sustainability issue, and you just reminded me that I was asked, and as I'm sure all of you have had, when I was in Wyoming, was asked, well, hey, Andy, is any part of the state not covered by EMS? And I said, well, define covered, because I'm pretty confident that given any range of time, somebody will get there. It might be 10 minutes, it might be 3 days, but eventually we're going to find you. So you got to narrow that down and being, figuring out how we're talking about that and what that looks like. That's going to be a key to all of this. Much more to say here, but we got some other questions that I think we ought to pivot to, just so we can get them out. And this is an interesting one. And I'm going to change the question just a little bit, because I think what the question is about, how do rural EMS and rural trauma systems, how do you assure that they have a seat at the table as you're thinking and talking about and doing your system planning across the state, especially and I'm making this assumption that we all got much more used to using things like Zoom and Microsoft Teams and all these platforms to stay connected with folks. So the question is, are you using that technology? Do you plan on continuing to use that technology to connect your rural EMS and trauma systems? And we'll go to Montana and start with Terry first on this one. What's that look like in Montana for now and the future?
Well, I think COVID has done us a bit of a favor. I think that we probably over the past 2 years have increased participation from those parts of the states which are at a significant distance from Helena, the capital, whether that be Northwest Montana, or Northeast Montana, or Southeast Montana, or Southwest Montana. All of them are just a click away from any meeting that they want to go to. And I think it's also made it easier for us as state officials to attend meetings that we might not have been able to attend. And so I think these past 2 years have been a great lesson for us. And I hope that we are able to continue to incorporate electronic participation in all of our meetings. I think that's going to be key.
Marty, let's go back to you in SD.
Yes, we utilize both. I mean, there's certainly utility in having face-to-face interaction, and we know we can't do that as frequently, especially when you know, like the comment said, 6 to 9 hours. I mean, that's a long time on the road. But you know, like Terry said, with what COVID has taught us, I mean, we can accomplish great things in a forum like this, being able to see people, being able to interact with people. Next best thing to in-person meetings. As far as performance improvement, we do a lot of that stuff over the internet, or forums such as this, very controlled, very specific because of the content. But we try to get together in different areas of the state. And I think that's one thing to the anonymous person that wrote this is maybe sometimes the state officials need to look at this and say, okay, if we're discriminating, not because we want to, but just, hey, this is a state capital, we're hosting the meetings here. Maybe sometimes the state representatives, we need to look at that and say, hey, we need to go out and maybe have a meeting elsewhere, because those face-to-face interactions, when you get out, just what I've noticed, just going out, having a cup of coffee and spending a little bit of time with you learn so much more than any meeting. But sometimes from a state perspective, I think we need to look at that and say, hey, how do we get out there? How do we do a better job interacting with these folks? So I think it goes both ways.
Yeah, excellent. And I'll say this because it's just another chance for me to make a plug here to all of you who are sitting in attendance. As you listen to what these folks are telling you, that this is a great bunch here. And I know that sitting out in the audience, we've got a couple of other state EMS directors. Dale Atkinson from Oklahoma is on, and Justin Romanella out of New Hampshire is on. And my challenge to all of you in attendance would be to say, hey, if you're in one of these states, or whatever state that you happen to be in, South Dakota or Utah or Montana, New Hampshire, reach out to these folks in your state and invite them to come out and visit your ambulance barn and your training meeting, and have them come out for a hot dog and a beer. I guarantee you almost everybody that's on this discussion right here will be out there in a heartbeat. Guy probably needs 2 or 3 hot dogs, but it's okay. They're looking for that. So be deliberate about it. Invite them out and say, hey, Marty, come on out and visit us, or hey, Guy, come on by and see what we're doing for training. If they can work it into their schedules, they will do it. I can speak for them with a surety. But Guy, let's go to you on that one. Shoot, I forget what question we were talking about.
That's my problem. I'm getting old.
Use of technology and making sure that rural EMS and trauma systems are connected.
Yeah. So well, I noticed in the question and answers, one of the questions about committee involvement and the rural participation in that. And Utah, we're fortunate that our legislature has allowed different departments to do virtual committee or virtual meetings as a way to conduct business. So that's been very helpful for us to be able to do that. And honestly, COVID has forced us to do a better job of that. So we have more rural participation, I would dare say now, because of the COVID experience. We always try to make them our special guests. Don't want to call them special, but I want to point out that the rural needs they do affect us all. And so we try to do that. Also, like you were saying about the training, we've moved to more virtual training for our, like the basic, for EMT courses and for those recertification and so forth. We've tried to be more flexible that way, and then do skills pass-offs and those kinds of things in-house with the local agency training officer, director, somebody like that to oversee those things. So those are ways. And then like you were talking about meeting with rural and frontier people. my heart's in rural Utah. I grew up in rural Utah. I've worked 10 years of my life before this job out in rural Utah. So I get it. I know about distances. I've been to those places, but I do enjoy, more than anything, I enjoy going to those places as part of my job now. And I have taken people up on the very thing. I was treated to sweet potatoes and steak instead of hot dogs last time I went out, but it is a big difference if you actually go out and see what's going on in the field. You can't explain it. You just have to see it and experience it. So I would advocate any of the other directors on the call, make sure that you take the time and effort to go see some of those places and be part of that frontier rural area so you understand what it's all about.
For sure. Katie, how about Washington? What about connecting with using technology to connect with your rural systems, and also your preference on hot dogs or steak?
Well, for technology, our state EMS committees always have a virtual option and have for years. So it's easy for rural communities to plug in if they want to participate and do some stakeholdering work with us. So that's something that exists. We do travel to different locations when we need to have meetings, or if we organically want to have meetings in those areas. A couple of things I'll say I think are important to consider is, in positions like ours, relationship capital is important for politics, and much of our work is political. And in terms of the importance of the rural voice at the table, your voice as a rural EMS provider is much more influential in the realm of relationship capital and in the realm of politics than ours is in some cases. So I just strongly advocate for the rural communities and the members in rural communities to continue using their voices, to continue to come to the table, because we need that. I can go forth and advocate on your behalf, but I don't have half a voice. You have much more influence than I do. With that said, relationship capital is also valuable in terms of my ability to do my job. If I don't understand your system, if I don't understand, what your challenges are from that in-person interaction and that, orientation to your environment, then I can't do a good job advocating for you. So my personal leadership style, it is to make those connections and, have that relationship capital in exchange where we build relationships, maintain relationships. I know you, you know me. So when I have opportunities, I always look for people to communicate with and connect with and do that with. And I hope all state EMS directors are doing that. And I hope all rural EMS providers are also working up to do that as we work down to do that. I think it's a combined effort for this inclusion.
Yeah, absolutely. Couldn't agree more, Katie. Man, I hope everyone just heard what Katie was laying down, as well as the others. I know almost all of the state EMS directors personally, and I'm telling you, they're a great bunch of folks. They live and they advocate and they work for all of you that are on attendance, whether you're in a hospital or on an ambulance service or what have you. And they want to hear from you. They want to know what's going on so that they can help work on your problems and work on those challenges together. Guy, we're going to go to you with the next question first off the bat. And it's always good to see a question pop in from a familiar name like Lindsay Narlock when she's dropping in there. That one's a shout out to Lindsay, formerly of the North Dakota State EMS office. But so it's a little bit of a switch. She's asking, what can we do to make dispatch better for our rural services? Is there a place for paramedic triage along with emergency medical dispatch? And I, of course, would answer that yes, because, why not? Why do we have to have nurse triage? But I'll let you I'll turf that question to you, Guy. And
yeah,
what are you doing in Utah?
So Utah is kind of a unique state. I don't know, most state directors, I don't think, have statutory authority over medical dispatch. Some do, some don't, I believe. Utah, we do. We have a clear distinction that we're responsible for the instructions and the caller instructions, and we have a designated requirement for dispatch centers to do medical dispatch. And we've tried to work on that piece for the last several years. One of the things we've required, we had a lot of homespun type of dispatching going on over the years, but most of them, and now in our in our requirements, our rules and our statute, they're required to have a vendor, a recognized dispatch protocol system. So there's probably 3 that come to mind right off the top of the bat. Our EMS committee has approved all 3 of those commercially available types. And we require that they use one of those, simply because some of the old types of dispatch protocols were probably obsolete or not consistent with what we know now. So that was one thing that kind of played in our favor. The paramedic dispatch, I honestly don't know much about that. Most of our all of our dispatchers are required to be EMD certified by their respective dispatch system. The vendor who provides that the protocols that they use, they're required to be trained in those and be proficient. And then they're also required to have quality assurance reviews on a percentage of calls. I think it's like 10% of the calls they have to do quality assurance reviews on those. And anyway, that's helped us. I don't know if there's a magic bullet on that one either. The paramedic idea I do like. Salt Lake City for a while did use a nurse in their dispatch to help triage patients. But we've never looked at using a paramedic as part of the dispatch group. We do have medical oversight on the dispatch centers, however, but anyway, hopefully that helped.
Yeah, thanks. And Terry, I'm going to go to you next. So while you're thinking and framing your answer there, just for anyone that's participating that may not be familiar, what Guy described as emergency medical dispatch is a course of training and certification for those call takers in the PSAPs or the 911 centers, the public safety answering points, to help them move through with a caller, an emergency caller online, to make sure that they're getting the appropriate resources that they need. What Lindsay was suggesting with her question was, when we think of, people often think of nurse triage, and when a call comes in, having a nurse, many of our nurse colleagues do this, takes the call and sees whether, do we really need an ambulance to be sent, or can we send this to some other resource? I know a lot of areas and states are using this, particularly as it relates to behavioral health and issues related to that. So what Lindsay's suggesting or asking is there a way that paramedics could do that along with emergency medical dispatch? And like I said, of course, Andy's answer is absolutely, we could do that. But I'll kick that over to Terry and let you give the Montana perspective.
And it's going to be a pretty quick perspective because I don't have a lot of background here. In Montana, we have no regulatory reach into the dispatch centers, but somehow, and I don't understand how, we have had a great relationship built over time, and we provide EMD training at the Law Enforcement Academy, and then we also provide EMD training for dispatch centers. And so it's something that's been successful here in Montana, but I can't describe how that happened. I think it is interesting to kind of just keep an eye on the ET3 program, as well as the various funding mechanisms for community paramedicine and telehealth, like Marty's program. I think that those will start to inform the EMD process as well as we move forward, and those programs become a little bit more established. So.
Okay. Marty, how about South Dakota?
Hey, Andy,
Yeah.
Really quick.
Yeah,
We've got 12 minutes. I just wanted to get you a quick warning, just 12 minutes.
Okay, Marty, you got 2.
Right. So big dichotomy in South Dakota. I mean, we obviously oversee the EMS services. We've got another branch, public safety, that oversees the dispatching. I think what Lindsay's proposing is a great idea, and one that I would certainly support. I think from a national level, we need to look at, where is dispatch? How are they interacting with EMS? How do we improve that process? And giving them the right tools that they need is going to be instrumental in saving patients' lives. So, there needs to be some work and initiatives there. But I would say to the state directors that are listening and those in the audience, I mean, we've got to have a good relationship with dispatch. We get a phone call here and there saying, "Hey, Marty, we might have an issue here. Can you look into it?" And within a couple of weeks, we've got, people around the table talking through system-related issues. So, I would certainly encourage everybody to reach out, befriend the dispatchers. They do an incredible job, incredible resource. So I just give that as my 2 cents here.
Yeah, awesome. Katie, how about Washington?
Well, like other states, Washington doesn't have any regulatory components that connect us or give us authority over dispatch. However, we do have an appointed position on the state dispatch advisory committee in our group, which offers a bridge between these two, tubes of efficiency or silos or systems. I think there's opportunity after COVID to look at how we can better connect. I certainly think there's opportunity in using paramedics, in some component of EMD, but I also pose the question back that is that the best level of care to use? In terms of dispatch centers and how they're operating and nurse triage lines and some of the community paramedic programs that are integrating dispatch protocols to do non-emergent type work. I think they're working very efficiently, and paramedics are expensive for rural communities. It takes a long time for them to train, and having their role be more in the system versus, in a dispatch center or in a dispatch role, I think might provide more value. But I think that you would need to do that assessment to determine what's the best person for the role that you're trying to create, and the best use of the resource in terms of workforce concerns that we have in EMS, recruiting and retaining adequate numbers of personnel. We have to diversify our workforce, and we don't need to dilute, our workforce to do more things. I think we need to create new types of, providers, new types of positions, bring more people into the system versus taking the one person and making them do multiple things. So that's just one approach and one opinion, but that's what I have for that.
Okay. So to the panelists, I want to see if we can cram 2 questions in here in the very remaining time. So I'm going to ask you to very quickly, I want to pivot to the ET3 here in just a second. And I'll start with you. We'll start with you, Guy, because I think I've only picked on you one time. But then the very last question that'll just kind of be a lightning round is just, I want to hit what are you worried about in the next 3 to 5 years? What's keeping you awake at night? So just limiting your answer. If you're on and you're not familiar with ET3, that's a program out of the Centers for Medicare and Medicaid Innovation Center to pilot, test, and fund transport to alternative destinations is at least part of it. It didn't really reach out into the rural areas in the way I think that they had hoped, but I want to get to ET3, get our state director to do that, and then very quickly we'll do a blitz on what's keeping you awake at night. But Guy, go on ET3.
Hey, yep, you nailed it. I think it's a great idea, but we didn't have much traction with it in Utah. We had some of the larger urban areas that looked at it, but nobody really jumped on the bandwagon. But I think the concept is great. So that's probably all I have.
All right. Terry, what about Montana?
As I understand it, none of the services in Montana were large enough to qualify for ET3 in the original funding proposal. I hope it comes back because I think it is, and I think it was Katie mentioned this earlier, I think if we can kind of fund alternate destination, we will in a way strengthen our rural EMS agencies, make it a little bit easier for them to recruit, reduce some of their call volumes and some of their long transports. Andy, do you want us to go ahead and talk about what keeps us up at night, or are you going to come back?
Well, I'll come back to that one. Let's get Katie and Marty on this ET3. Marty, what about ET3?
Fully supported. I hope it comes around and that we get CMS, involvement from a reimbursement perspective. I mean, this is going to be key. Not every patient needs to go to the hospital. I think Terry alluded to it before, looking at community health workers as an alternative, which is currently reimbursed in some states. So I'll be quick with that comment.
All right. Katie?
In Washington, we didn't have any providers participate in ET3, but I do think it's important for CMS to evolve the pilot to continue. I do think pushing our payers to increase the reimbursement for the out-of-hospital care and the types and models that are emerging is really important, which is the important part of staying in touch with ET3, staying in tune with these efforts, advocating for them to extend it. I think that's critical because without reimbursement to do these evolving models, we're limited at sustaining them after our incentive funding. So that's what I have to say about that.
Awesome. All right, here's our lightning round. Last question. What are you worried about? What's keeping you awake at night? Go, Terry.
I have I call it figure out what's important. And if something's important, figure out a way to teach it. If you figure out a way to teach it, you got to figure out a way to measure it. If you figure out a way to measure it, figure out a way to improve it. So we're like squirrels in EMS. We get an idea, we're off and running and throwing assets at it. And what we need to do is we need to figure out a way to kind of focus on what's important, utilize our staff efficiently. That's the stuff that keeps me awake.
All right, Guy, what about you?
I think I've already touched on them. I think the staffing shortages is definitely one of them. Funding is obviously one of them. How we can become of value to our communities is something that I think about often. One thing I would think is a huge success in Utah, I alluded to it in my comment, was that we have an association of rural EMS directors. And that used to keep me awake at night. And now I sleep better because of them.
Well put. Katie, what about Washington?
What keeps me up at night is staffing challenges, reimbursement, wanting to see EMS have more reimbursement. And I think interfacility transport resources, when we saw in COVID, we had difficulty moving patients statewide, being able to manage that and address those concerns. And yeah, I think that's what would keep me up at night.
Understood. Marty.
Well, I think workforce is certainly the biggest one to me. But the other thing is just having a paradigm shift of how we approach EMS, how we look at EMS. And when I sit in my office, oftentimes I'm like, okay, how do we deal with the workforce? How do we get more people? And how do we do recruitment and retention appropriately? But sometimes that comes back to, are we doing right the way we're functioning right now? Is there a service line differential that we can go into that would increase revenue for EMS services? Something different that we're not seeing right now. And I think that's one of my biggest things is just, exploring those opportunities that are out there that we can potentially capitalize on. And I would say lastly is just, the wonderful folks out there in the work that they're doing. I mean, these people are giving everything of themselves, and for us to be supportive of them, encouraging others to be supportive of them, they do an outstanding job, and we've got to advocate for them as much as we can.
Yeah, understood. Panelists, I thank you so very much for being willing to join and answer questions and be in the hot seat, and Katie for joining at the very last minute. To the state EMS directors sitting in the audience, I see you. Sorry we didn't get you all pulled in, and to all of you, the rest of you in the audience, we want to, on behalf of the panelists, I want to say thank you. And again, tell you, find your state EMS office wherever you might be, reach out to them, extend them that invite. They want to hear from you. They want to work with you. They're out there every day advocating on your behalf. So find your Terry, Guy, Katie, or Marty, wherever that might be, and reach out to them. And Matt, I think that brings us to an end, almost on the dot by my watch anyway.
Almost on the dot, 2 minutes. In those 2 minutes, can you answer what an EMD is?
Yeah, sure. I see that question there. And the question reads, what is an EMB? And I think you might have heard EMD when Guy was using it, which stands for Emergency Medical Dispatch, which would not be the same as a first responder. Later in the question there, you mentioned the EMR, which is, there may be some states out there that have not recognized that level, or they still maintain their other name, but generally, responder is what old guys like Terry and me and Guy and Marty all grew up knowing as the first responder. And back in the day, that amounted to CPR and some first aid training, I think. And then we all jumped in the trucks and went really fast to wherever it was we were going. But yeah, I think that was the answer to your question. So.
Perfect. All right. Well, I think we're right at the end. Andy, thank you so much for moderating this. Marty, Terry, Guy, thanks for being on here. Katie, thanks for getting put in the hot seat real quick right at the beginning. Thought you were going to enjoy that first session by just listening, and we got you in there, but I really appreciate you joining on there. So thank you, everybody. Good first session. And I believe we're going to leave Marty on, and we'll go grab Nicole and Aaron for the next session.